Hi, everybody. Thanks for joining. This is the October 2022 Journal Club session. We are focusing on infectious disease and international and travel medicine. In lieu of articles this month, we have a infectious disease specialist who has joined us, Dr. Jordan Abel. He'll be giving us a presentation, and rather than listen to me all night, I'm going to hand the floor over to him, and share screen should be enabled. And I'm going to mute myself. Take it away.
Hi, everyone. Nice to meet everybody here through Zoom. I know, this is the holdout from COVID, so we're all excited to use Zoom again. I certainly am. So hopefully this screen share is going to work here. Let's see if I can get this working. So it's doing it on a new computer, so let me see if I can activate this. I have to reopen the meeting, so sorry. Let me join it again.
If you, well, I was going to say if he needs me, I've got it as a backup, but we'll hang out for a minute. In the meantime, he's going to be covering a lot regarding counseling patients on what meds they should take with them, how to source meds if you are the expedition doc, what you should have in your kit if you are a medical provider, and how to know what is appropriate based on where your patient has been or where you are going on your trip.
We should ask for some real-time flu and COVID predictions for the upcoming months.
Yeah, RSV is probably just going to be awful all winter. And flu A.
Yeah, we're going to have the trifecta, it looks like. Sorry about that, guys. All right. How are we doing? Sorry, I didn't realize I didn't even get permission to this thing. That's embarrassing. Okay. Well, we're off to a great start. Okay. Can everyone see the screen, the entry screen, the initial slide?
Yes.
Yes.
Okay, great. All right. Let me try to minimize this here. Okay, no clue how that's going to work. Okay, so I'm Jordan Abel, one of the, I actually work with Justin's mother-in-law, and so we were connected earlier this year and had been kind of brainstorming about something to do this fall. And some of the big questions that seem to be coming up are how to prepare for trips, what vaccinations to get, where to go, who to talk to, what things to think about. And this is, so I put together a quick presentation, basically kind of do an overview of a lot of the things that I think about prior to travel and things that I would recommend to patients. In my former COVID life, I did quite a few medical mission trips to Guatemala every 3 months, to Uganda, as well as to a local hospital in Kenya. So I have a little bit of experience in managing my own health when I'm traveling, but also in managing teams. So I thought I would use some of that expertise tonight to kind of go over some of these very common issues to have a great trip and also reduce any risk of any acquired issues over international travel. So that being said, just a brief overview, travel statistics. So travel over the last decade has nearly doubled. So with about 1.4 billion people traveling in the last year or so, with about 20% traveling to the developing world. This, of course, pertains a higher risk of acquiring infections and issues with travel. Obviously, with COVID, there's been a decrease, but rapidly travel has increased back to pretty much pre-pandemic levels and is projected to have pretty substantial volume. So this, of course, means more people are going to be getting exposed to international diseases. The other issue that's coming up is with global warming, we're having quite a bit of change in disease patterns, and these are changing pretty rapidly. So it's more and more important, I think, for travelers to see and seek expert care prior to trips, particularly if you have comorbid conditions, if you're trying to get pregnant, if you're going to a unique, particular itinerary, if you're doing a medical mission trip, which might expose you to additional risks on that trip. It is certainly worth getting expert advice prior to that trip. Most people typically will see their primary care doctor, which in general is probably just fine. However, like I said, I think that it is important with certain itineraries to seek out specialty care. Stressing that point, basically that, up to 60% of people have some sort of issue when they come back, whether it be a rash, a fever, diarrhea, something. So this really only drives home the point that you really probably should seek some kind of care prior in order to reduce that risk of issues, with health over from your trip, basically. I'll point out a special group of travelers that are pretty much on the naughty list, I think, in terms of getting issues with travel, and that would be visiting friends and relatives. This group of patients classically seeks care less prior to travel, probably because they're just a lot more comfortable with the destination because they're going to go see friends and relatives, and they probably have some sort of perceived comfort in that. However, unfortunately, they do tend to get sick more often. So in this study in clinical infectious disease from 2006, I'll point out this malaria line here. They are far more likely, this is the middle column here, this is like a traveler from the United States to a developing country. They're far more likely to get malaria compared to a tourist traveler. And essentially this is probably because they don't tend to seek care, like we said, and they don't tend to take medications prior to travel, or they stop because they feel like, oh, they're safe, or they've had malaria before. And so this is a pretty important point, I think, with this type of traveler, is that they definitely are much more likely to have issues when coming home from trips. So don't be fooled. If you're visiting friends and relatives, you are not immune from infectious diseases. And particularly, I think this is a great study that pointed that out pretty nicely. General advice. So some of this stuff probably seems pedantic and maybe repetitive and pretty obvious. However, it is always worth going over some of the general pieces of advice. And this is generally what I do with my groups before we head out. We have a handout, we go extensively over this and really do checklists and make sure everybody is aware of and has the right equipment and knows how to use it. But basically, the best medicine in general is preventing even just the bite itself, just getting exposed to the mosquito. That alone, in combination with medications like we'll talk about briefly in a little bit here, is the most powerful way to prevent disease. So of course, bed nets for sleeping certainly saved me in Africa, because you wake up, there's about 1,000 mosquitoes trying to get in there. So that's pretty helpful to have a good bed net. Having appropriate sprays with you, recommending at least 30 to 50% DEET. Of course, the picture I have here is 100, but certainly not necessarily to go that strong always, but 30 to 50% DEET. There are multiple other types of sprays and topical ointments, if you're not comfortable with DEET, that are certainly available pretty readily from Amazon. Certainly worth having those and packing those in your bag. Proper clothing, covering your skin. Light colored clothing so that you can identify ticks that have attached to you. These are all pretty just sort of basic things that you need to think about before you head out. Finally, taking medications properly. This is one of the most important things that I can't stress enough. This is mainly why people who come home and have acquired malaria abroad is because they simply just did not take their medications properly. The medications themselves are easily 95+% effective. So taking your medications properly is one of the most important things. This was something I had to stress to my medical students. We had a check-in every morning on our trips, and some of them were on the naughty list, I will say. So we had to really stick with it. But I think this is just something to really stress. It seems kind of silly, but definitely worth just pointing out that stopping medications would massively increase your risk of having a problem. Food and water practices. So I'm certainly guilty of heading straight to the salsa bar whenever I arrive somewhere. So yeah, so just making sure you're aware of what foods are and water it would be high risk. So basically, anything that doesn't have a peel, anything that's not cooked or hot, anything that's like a fresh food, salads would be high risk. Salsas are very high risk. Just being aware of that list of foods and beverages that would be, increasing your chance of having some kind of foodborne illness, that you think that, okay, I took the typhoid vaccine, that you're just fine. Well, you're actually not, because it's only 50-ish% effective. So just being aware of those things. But studies have shown that up to 90% of people within a couple of days of arrival get comfortable right away and, are hitting the street carts and, probably ignoring general advice. So just something to stress. Freshwater contact would be another thing to think about, particularly in Africa. And some of these more adventure travels, freshwater contact would be an exposure to schistosomiasis, to leptospirosis, could even be contaminated with fecal matter. So you could be, there were some issues in Guatemala when we were swimming, near some of the cities that, certainly they don't have the same kind of sewage systems we have. So just being aware that fresh water pertains a much higher risk of acquiring a disease. Safe behavior goes without saying. CDC shows that most accidents and most issues that Americans have abroad, which would be death or injury, come from traffic accidents, simple accidents that you can avoid with helmets, seat belts, scooter accidents, jumping on the back of a scooter or on the back of a bicycle, not paying attention to stuff, avoiding certain areas of town, traveling in groups, safe sex. All of these things are worth just pointing out and really reiterating. It's you're not immune when you go on a trip, and I know people are excited to go on to go on an adventure, to go on travel, but you can definitely have some issues, and I think people sometimes forget that they are not immune from these issues. The other thing I'd point out is to having some precautions and pre-medications, making sure that the itinerary doesn't include some high altitude exposure. That would be something else to think about. Some of these locations in South America, maybe you're going to go climb Kilimanjaro, maybe you're going to do some other things that include high altitude exposure. That would be certainly worth exploring with the patient and making sure that they have the proper medication, Diamox or acetazolamide, which they can take prior to acclimation. Resources, the kind of, basically the gold standard would be the CDC Yellow Book. This is what I use very frequently. It's very readily available on the CDC website. It is very comprehensive compendium of pretty much most diseases and locations. It has travel advisories. It's a really fantastic resource that I think that I use very frequently. I'll also point out the Travex, which I haven't personally used, but is a subscription service that can actually print out a individualized sheet based on your destination with warnings and advisories. And that's actually an excellent concise thing that you can print out and give to the patient. World Health Organization also has quite a bit of resources as well particularly for the polio countries that you need a booster for and other travel warnings. So that's certainly worth taking a look at prior to trips. I'll point out that we used actually this US State Department travel warnings. You can actually register with the State Department, and I would recommend doing this for some of the higher risk countries. You can enroll in email and text updates that I think are certainly worth taking a look at, and it will be very up to date travel advisories that can help understand particular areas of unrest. We used this actually in Uganda. We had some issues with some political unrest that came up at the last minute that was actually pretty helpful. So I think that registering with them is pretty helpful prior to the trip. A lot of people don't, maybe especially if you're younger, I certainly did years ago, blow off travel insurance. I would highly recommend this. it's pretty cheap in general, and it may actually be included in the credit card that you purchased your trip with, but you may want to consider additional coverage for especially remote trips, trips that's going to, might expose you to, I don't know, you might be somewhere in a small village and get a dog bite or something. It's going to be really tough to get out of there. And if you have travel insurance, that's pretty helpful actually. So I would highly recommend taking a look at this prior to trips. So let's go ahead and get started. Just a quick overview of some of the big diseases. The most important is going to be malaria because it is probably the most deadly parasitic infection worldwide. And it's going to be one of the biggest risks to travelers. You can go, especially non-immune patients can go from basically healthy to dead in a matter of days. So I think it's important to really stress this disease. There's basically 5 important human Plasmodium species, Falciparum being the most important. This is the one that's most responsible for death and severe disease, particularly, like I said, in non-immune. There's also Vivax, Ovale, malaria, and Nulci. But Falciparum is going to be the most important of all the species. It's transmitted by the female Anopheles mosquito, and it's typically transmitted during nighttime biting. This is why bed nets are critical in reducing the risk of exposure to this parasite. I mentioned also just proper clothing and DEET sprays, as we talked about earlier, in general precautions. We already talked about that this can result in rapid death, basically, for non-immune patients. And so I would really stress that. And basically, this is responsible for more than 1 million deaths, with nearly half of Earth's population at risk. So certainly any kind of travel to an endemic area, you definitely need to be on appropriate prophylaxis, making sure you check with your either primary care doc or travel clinic by looking at the CDC Yellow Book. The map, country-specific map down to the district, can really help you understand what your risk is. And as I said earlier, most infections are a result of improper medication adherence. So medications, when taken appropriately, are highly effective at preventing this. So I would highly recommend it. The one patient I saw back in San Antonio, she went to Africa to learn how to dance and decided halfway through she didn't need her medication. Well, guess who ended up in the ICU about 3 weeks after coming home? So she certainly was regretful of that, and she did just fine, thankfully. But I would say that she easily could have prevented that hospital stay by taking her medication. So here's a map basically showing the endemic area, with the focus being basically in most of the tropics of Africa. There are select areas, in Central America, South America, Asia, of course, but the highest rates of malaria are going to basically be in the tropics of Africa. So itineraries including these areas should definitely include malaria prophylaxis. Risk of malaria. So this is a study from Infectious Disease Clinic from 2005, showed, if you see here, for 1 month of travel without medication, if you look here at Papua New Guinea, 1 in 17. So there's quite a massive risk. Now I know most people aren't going to be going to Papua New Guinea, and it is not Falciparum there. I think they have Vivax. Just basically showing that, risk is quite high, especially with West Africa. Let's see if I can move this. West Africa being some of the highest risk, and East Africa, 1 in 40 is, pretty significant. So very important, again, just stressing, bringing home the point of taking chemoprophylaxis when you travel. So malaria, the incubation period is at least a week. If you arrive and within a week have a fever, it's probably something else, something acquired in transit, something, from prior to departure. But you need at least 7 days or so of exposure after exposure to acquire malaria. So you can, of course, have a delayed response, so up to a month out after infection. And of course, there's relapse periods that can be up to years. with Vivax and Ovali due to the hypnozoite formation in the liver. So those would be more considerations for people coming back and needing to, for evaluation. But basically, you're going to be within a week or so or longer, that's usually when you would acquire this. It's a pretty generic presentation with pretty high fevers, cyclical fevers, rigors, lethargy, sweating, pretty non-specific symptoms. So you would need just a pretty good workup to figure out what's going on. But essentially, those are the kind of generic symptoms you're going to see. Malaria, so chloroquine was our first primary chemoprophylaxis. Then it was introduced in the 50s and 60s, where of course was rapidly developed, where falciparum, the primary one we were trying to get after, rapidly developed resistance. So if you can use chloroquine, which is in a very small select itinerary, which would be, the southern part of Mexico, Central America, a small foci in South America, which I think is in the Bolivian and in Paraguay. And then of course, in parts of the Middle East, that's where you basically would use chloroquine. This is the primary drug you should use for those itineraries because it's very well tolerated, it's cheap, and it's a pretty easy medication to take. So for those itineraries, I would definitely use that. But for the rest of the world, resistance is rampant. And so unfortunately, you would need to select a different chemoprophylaxis, which we'll go over in just a second. Followed by chloroquine, we then developed mefloquine, which unfortunately also about a decade after that developed severe, pretty widespread resistance in Southeast Asia. So again, just needing to be specific about reviewing our itinerary prior to travel, knowing exactly where people are going to select the right agent. So the primary drug that we use is basically Malarone. This is the atovaquone proguanil. Pretty easy and well tolerated. It's going to be probably the preferred agent for most trips and itineraries, especially good for short trips as well, mainly because you only need to take it for a couple of days prior and then about a week after you conclude the trip, which is great because most of these other options you need to take for approximately a month afterwards. Cost can be an issue. I think the last time I took a look at the, when I checked up to date, it looked like it was $6 or $7 for a tab. So the cost can be quite substantial. However, for short trips, like I said, it might be, a reasonable to still do that one. Mefloquine with Southeast Asia excluded would be another option. Definitely better for longer trips simply because it's a once a week drug, which is a nice benefit if you're going for many months at a time. Cost could be an issue there too, but I think ultimately this is a pretty good option as well. Doxycycline is another good option, very cheap, pretty well tolerated, does have some side effects that we'll talk about in a second. Downside, of course, is that you got to take it for a month afterwards. Primaquine or difenaquine, both of those, I haven't used either of these before in the past, but also the one benefit would be that you take it for a week after. Important side effects, Malarone, like I said, is pretty well tolerated. Generally, you're going to have some nausea or abdominal pain. It's not really recommended for people who have chronic kidney disease. Can also cause mouth ulcers, but generally, this has a very, very well tolerated side effect profile. Mefloquine, I think this one gets probably a pretty bad rap because of the neuropsychotropic effects, the potential for exacerbating bipolar, the dreams. It does have a pretty bad rap in general from that, but typically it's pretty well tolerated. And ultimately, I think it's, like we said, for long trips, this would be probably a drug to consider. But a lot of people shy away from it from the psychiatric issue and probably opt for Malarone. Doxycycline, generally pretty well tolerated medication if taken properly with plenty of water. We do see a lot of GI intolerance and esophagitis from this. Unfortunately, one of our trips, the medical student unfortunately didn't take it with plenty of water, ended up with a pretty severe case of pill esophagitis, and we had to actually fly them home ended up with a GI bleed. It was pretty tough end of their trip. So you can have some pretty bad downsides to this. Photosensitivity as well, which can be certainly a problem when you're traveling to some of these tropical areas where you're getting exposed to a lot of sun. So that can be an issue as well. Side benefit would be that it would protect against atypical infections such as rickettsial infections. So if you are going to do some hiking while you're there or going on safari in South Africa, there may be some additional protection there with that. Permaquin and basically you would need to look for G6PD deficiency. One of the primary side effects would be hemolytic anemia. Like I said, it's not one that I've used too much. Chloroquine, primary side effects would be nausea, dizziness, and blurry vision. Now, most of the studies have shown that all of these above can be used safely for 2 years. So if people are going for extended periods of time, long assignments, long missions, there's no excuse to not continue taking chemoprophylaxis, and you definitely should. Studies have really shown most of these can be used for extended periods of time. I think tafenoquine is the only one that can only be used for 6 months, I think, from what I remember. So the thing I would also caution against is acquiring the medications while abroad. So there's actually quite a high rate of counterfeit medications in these developing countries, particularly in Asia and Africa. So acquiring these meds, on the fly or on the trip, I would proceed with extreme caution in that case. You really don't want these meds to fail. So you definitely want to be making sure you're taking, the actual medication and not a counterfeit. So something just to think about if you don't, another reason to, get your medications before you leave and here in the United States. Another thing to consider, especially for some of these trips where you're out in the wild, kind of in the remote areas, you may consider bringing a couple courses of Coartem, which would be the treatment course for malaria. Sometimes you might find it hard to get the medications while you're somewhere. We actually, in Africa, we didn't have any issues getting Coartem. We used it a lot in some of our pop-up clinics, so we didn't have any problem acquiring it. Now, again, counterfeit could be an issue, but this is something certainly worth just having kind of in your bag, maybe this would be sort of a case-by-case evaluation. So I would something to think about just having, because certainly with such a high risk of issues with falciparum, you want to have this on board if you think someone has malaria, and you want to have the medication available right away to start it. So let's move over to the immunizations. We'll do a brief overview of kind of how I approach immunizations with each of our groups. So we'll first start with the routine immunizations. These are just the ones you're going to have on board, anyway. So you want to make sure that you're up to date on your Tdap, which would be every 10 years, MMR. For those born prior to 1957, you may want to consider a booster for those patients because they may not have been fully immunized prior to that year. Of course, seasonal flu, want to make sure you're up to date on that. Something to think about with flu, of course, is also that flu in the tropics or on cruise ships would be something you can get any time of the year. So I would really make sure that you may want to consider getting the flu shot early if you're traveling. Hepatitis A is actually one that now, a lot of kids have gotten. So this is a kind of a newer recommendation. So for older patients who may not have traveled or who haven't been exposed or who didn't get immunized, I would recommend getting the hepatitis A vaccine series, and we'll go over that in a second. Hepatitis B for select cases. So if you're going to be exposed potentially to needle sticks, blood, you may want to consider checking a titer. Just a personal anecdote, when I got employed a couple of years ago, I had to get my Hep B titer, and I was actually non-immune, so I had to get boosted. So it may be something to consider checking if you think you're going to get into a situation where you could get exposed. COVID, of course, is a new one now on the list. So making sure you're boosted on your COVID, fully vaccinated. Polio would be another one. So if you've received the primary vaccine series, which would be prior to 2000, most people should have received primary vaccine series. There is a recommended one-time booster for select locations, and you would just need to check the World Health Organization website. This changes with time. So there would be a list of countries they would recommend one-time booster for that. And that's simply because we do use an oral inactivated virus that could potentially cause clinical disease. And so we do recommend that. Varicella would be the other one to make sure that you've either had clinical disease or that you've been vaccinated in your lifetime for that, because this is something you can definitely acquire abroad. So let's talk a little bit about yellow fever. So flavivirus that is similar to West Nile and the St. Louis encephalitis virus. It's endemic in West Africa and South Africa and spread by the Aedes or homonymous mosquito. Most people are going to have asymptomatic disease or mild disease. However, in a small portion of patients, you could result in shock, jaundice, multi-organ failure, and hemorrhage. It's a pretty devastating disease to get. And of those who develop severe disease, kind of up to 60% case fatality rate. So it's certainly worth getting evaluated for this. This is one of the, probably the real benefit of going to a travel medicine clinic would be to be truly evaluated for yellow fever immunization, because this would be something that would be very local in certain areas. For instance, if you go to Brazil, it's not every part of Brazil that's going to be recommended for. So, but if you are down to the district, you can actually look at the CDC Yellow Book, and they're able to show you exactly where you would need to get the vaccine to protect you from this. Where maybe if you're having a local outbreak in that area. So basically, here the map does change pretty frequently. Like I said, there's some changing geographic distribution of this, probably because of global warming and changing in climate. But for instance, Tanzania was taken off the list about 10 years ago. Now there's areas of Kenya that are included. Coast of Brazil in the past, now on outbreak, so people are recommending a vaccine for those areas. So just something that certainly worth taking a look at your itinerary prior to travel. You want to have careful consideration, particularly for those who are 60 and older, and especially those who are 70 and older. The reason being, you can have pretty significant and even fatal vaccine-associated reactions. One of them is viscotropic disease, which has a 50% fatality rate. Now, it's not common to get this, but it can result in pretty significant, problem inside vaccine side effects. So it's certainly worth exploring this with your patient, checking their itinerary, making sure it's appropriate. The other thing that is important to remember about yellow fever is that if you're traveling from an endemic country into a non-endemic country, there is international law that can prevent you from coming into that country. So you must have documentation of yellow fever vaccination within 10 days or more of arrival to that country. Or you need a letter exempting you basically from the vaccine. So the reason we look at 10 days or more is because that's when immunity starts. So that's why that's an important thing to remember when you show up, because there were some issues when I was traveling from Tanzania back to Kenya. They definitely did check this. And so, from Kenya to Tanzania, because it's no longer on the list. So definitely something you need to have your form with you. So in the past, there was a booster that was recommended every 10 years. That's no longer recommended. There are certain individuals that we would recommend that for. And if you remember from the map of the coast of Brazil, if there's an ongoing outbreak, you may consider administering an additional dose 10 years, more than 10 years out, to protect in an ongoing outbreak where the risk is higher of acquiring the disease. It's an inactivated virus, so there are some important populations that are excluded from getting this, and that would be patients who are immunocompromised, those receiving biologic agents, those with AIDS with a CD4 count less than 200, and you may want to really counsel your patient with someone living with HIV about receiving the vaccine. Those who are less than 9 years old, those with thymus disease are pretty important exclusions from this vaccine, and those people should get an exclusion letter that they can then use to enter the country. The next one we'll go over real quick is meningococcal. So there are a number of different conjugate vaccines that cover 4 different serotypes. And basically we recommend this for those traveling to the meningitis belt. Sorry about the typo there. Yeah, in Africa, which is basically the area south of the Sahara, but not quite tropical. This is basically, let me see if there's, let's see that. Oh yeah, here we are. So basically if they're traveling during certain times of the year, which would be the dry season, December to June, which typically those outbreaks are associated with type C and W meningitis. Those are the patients we would definitely recommend getting one of these conjugate vaccines for. It's also required for travel to Mecca during the Hajj. And there's also important local outbreaks that we just now are dealing with in Miami, which I think is type C meningitis. Many college students have already gotten this, so you may be just be evaluating a patient to consider them for a booster every 5 years, because college students have already received this. So it's another one to think about. Hepatitis A, as I said, this is now recommended for, as a routine vaccination for kids, but adults who may not have been vaccinated should be definitely considered for this vaccine. The risk when traveling to the endemic areas, which is basically the entire developing world, would be 3 in 1,000, which is pretty significant. So I would definitely recommend considering this vaccine. I'll also point out that I've actually had a few friends, one of which got it in Portugal and another got it in Italy. So North America is not typically considered, an endemic area for this, but I would definitely consider, getting Hep A if you haven't been vaccinated at some point in your life. Fecal oral, of course. The vaccine is a 2-dose series, 6 months apart. So, this kind of raises the question of when do you go see, before travel. If you are imminently traveling, you can get pretty good protection at 2 weeks. So in the past, people would be given IVIG if they're leaving really quickly. However, if you're leaving, within 5 to 10 days, you can probably get the first vaccine and you're going to have about 85% protection, I think, at about 2 weeks. So just trying to be very careful up front at the beginning of your trip. You're probably going to have pretty decent protection. And I would also point out that it's a devastating illness in immunocompromised patients. So I think that, definitely want to consider that for that patient population. Japanese encephalitis is another important vaccine to consider and is also very geographic and pretty important to think about certain travelers. So not everyone really would need to get this vaccine. It's typically transmitted by the Culex mosquitoes during the monsoon season, which is the summer and fall typically. Most people have no disease at all or very asymptomatic, have very mild symptoms. They wouldn't even notice that they're actually having this virus. But if you are symptomatic, about a third die. So it's pretty significant and would be certainly worth considering this vaccine for some certain patients. I would say that people going to rural areas, so because it's amplified by pigs and wading birds during that season, anyone who's going for prolonged travel to any one of these countries really should consider getting this 2-dose series. Mainly I would say long-term travelers would be the highest, would be the most benefit the most from getting this vaccine. Rabies is another pretty interesting one to consider. Certainly an optional vaccine given the cost, which can be pretty substantial. But it is, as everyone knows, a horrible disease if symptomatic. It kills about 60,000 people worldwide. We have very, very few cases here in the United States, and typically they're acquired abroad. But as you know, it's about 100% fatal. The only few known survivors really of this. So prevention is critical here. Cost is a massive barrier. Each shot, I think the last time I checked was $486, which is pretty significant. And you're going to need 4 doses. So that can be a substantial cost in general. But I would definitely consider this for certain people. Definitely if you're going to be around animals, if you're a medical worker working in rural areas, if you're a veterinarian, if you're traveling, I would definitely consider this because let me tell you what, if you end up with a bite and have to be medically evacuated, it's going to be really tough, and trying to find rig, it's going to be a real big challenge. So it's basically that they've just recently changed the recommendation to 2 doses on day 0 and day 7. There is a booster recommendation for based on risk category. There's 4 risk categories, and so there can be a booster required after this primary vaccine series, but it essentially eliminates the need for rabies immunoglobulin, which can be an extremely challenging medication to find in the developing world. So it also, you're going to end up with probably an emergency evacuation if you end up with a bite or some kind of exposure. So it definitely will take a lot of that worry out of that type of situation. So the vaccine risk would be headaches, myalgias. About 5% or less have an immune complex reaction that's like malaise and hives. But basically, I've actually thought about getting this vaccine myself. A lot of the clinics we went to had a lot of dogs just hanging out. I don't know if a one-time visitor for one of our clinics would have been worth getting the vaccine series, but when you're dealing with going repetitively to a site and you're going to be out in the countryside, it's over time, I think it's worth it for the risk, just because it definitely would take a lot of that worry out, and it's a pretty dramatic thing that you have to deal with if you do end up with a bite. You'll be on a flight to Singapore before you know it, trying to find rig. So, of course, important to wash any bites immediately. And if you're, like I said, if you're previously vaccinated, you're just going to end up with a booster basically. And then of course, local wound care and that kind of thing. So I didn't really go into detail, but on these, but I did think it was worth just mentioning something to think about. So the other vaccines I would kind of look at for various select populations would be like a cholera vaccine. So like in Haiti right now, they're having an outbreak of cholera. Monkeypox, which thankfully looks like it's downtrending, but that would be another one to consider, like if you're traveling, doing some medical work. And Ebola even, of course, there's an Ebola vaccine. We actually looked into getting this for our Uganda trip, and we weren't able to successfully figure out actually how to get the vaccine. But I think that's one that you could consider. This would be, again, a very specific situation that you'd find yourself in if you're like heading to DRC or something for some medical work. I think that would be something you should try to look into and figure out if you can possibly get that, but those vaccines are available. Another vaccine or immunization that we'll talk about real quick here is typhoid, so enteric fever. Again, fecal oral, just like Hep A, endemic in the developing world. Multi-drug resistant strains, India, Pakistan can have very extensively drug resistant strains. Incubation period is 1 to 2 weeks, can even result in GI bleeding or perforation. We have 2 different forms available. The one I actually prefer probably is this oral live attenuated for 2 reasons. The first being that it's a 5-year vaccination, 5-year vaccination period. So it does require refrigeration and taken over 8 days. You can just put it in your fridge at your house once you acquire the vaccine. And then it also has an additional potential protective feature to paratyphi B. So I think that's a little bit of an advantage over the injectable capsular polysaccharide, which is the other option, which requires a vaccine redosing at 2 years. Far from perfect vaccine, of course, 50 to 80% effective. And like I said, food and water safety practices would be continue to be stressed. Traveler's diarrhea, definitely one that has plagued most people that I know. So very different from developed country, which, mostly is viral. It's 80% bacterial in some studies with international and travel developing countries. So usually the 2-week traveler has a 30% risk, which is, pretty substantial. Again, safe food and water practices. Something that is kind of an interesting thing to point out is prophylactic bismuth, which is 524 milligrams 4 times daily, can decrease adherence of the pathogenic bacteria to the colon wall, thought to pretty significantly reduce attack rates. So that's a pretty cheap, medication you can try. We really don't recommend prophylactic antibiotics, mainly because of the side effects, increased drug resistance, all sorts of issues that you can have. But if you do want to, if there are some very critical situations where you might consider taking medications, and rifaximin probably would be one of them that has pretty low C. diff risk, but could be fairly costly. So that would be one to consider. Self-treatment, of course, is waning, but for some of these trips and itineraries, it is, sometimes it's reasonable to have at least the option there for, especially for severe cases, if you're getting pretty dehydrated or fevering, just, not looking very good. So azithromycin is the new recommendation, 1 gram once or 500 milligrams daily for 3 doses. You can use this in conjunction with an anti-motility agent. Probably shouldn't use that independently, because you want to make sure you're being treated at least for this infection. Sometimes you can have quite a bit of nausea with 1 gram once. So I would say that taking the 500 over 3 days could be potentially better if you're not able to tolerate the 1 gram. And this is basically because of fluoroquinolone resistance, where we're seeing, especially Southeast Asia, we're seeing, above 90% resistance to fluoroquinolones with some of the enteric pathogens. So that's why we've switched over to azithromycin. So certainly worth considering getting a short treatment course, a couple of doses with this to bring with you in your bag, just in case you develop some pretty severe diarrhea. Another thing to consider would be dengue. No treatment available for this, unfortunately, but so it's all prevention. Also a flavivirus, unfortunately no vaccine. It does have a different transmission pattern than malaria because it's spread by a different type of mosquito, the Aedes aegypti, and it has opposite behavior to Anopheles. So it's daytime biting, urban. So you see a lot more dengue in urban settings. It has a incubation period of about a week. Classical symptoms of fever, headaches, myalgias, rash, thrombocytopenia. In a very small percentage of cases, you can get hemorrhagic shock. Pretty devastating. But again, preventative measures, clothing, sprays, netting are going to be your primary way to avoid this. Freshwater contact is something worth mentioning. So schistosomiasis basically does not require any cut in your skin, just needs direct contact. You can be inoculated with completely normal skin. Early disease would be resulting in a dermatitis, like you can see here on the picture that I included. It's endemic in nearly all of Africa and Asia, so I would avoid, basically any canoeing trips out in Lake Victoria, probably not a great idea. Leptospirosis would be another thing to think about. Unfortunately, I actually haven't personally seen any cases of leptospirosis, but definitely something to consider, especially in a returning traveler who decided to go for that rafting trip. But typically it's been mucosal exposure, so eyes or mouth. Can be mild illness, but of course sometimes quite severe. African tick bite, so this would be something to think about for people doing a South African safari. One of my colleagues actually just had a case of this a couple years ago, and the patient did just fine with doxy, but definitely was able to find the eschar caused by Rickettsia africae. Tick-borne disease, of course. So again, preventative measures. This is something to think about definitely when returning traveler. So some medications to consider. I would definitely think about, sometimes people kind of forget about maybe getting some additional month or two of their home medications, and they're sort of in a scramble the last few days before a trip. But if you're on chronic medications, making sure you have, an additional refill. One primary medication that I use quite a bit, and I was glad I've always had, was the Zofran or ondansetron. I think that's a great thing to have on board, especially if, travel sometimes can cause you to feel a little bit nauseous, maybe gets a little bit of mild diarrhea. Zofran's really great. The oral disintegrating tab is great to have, and pretty readily available. So Phenergan and Reglan would be other options to have with you. We spoke a little bit ago about, with traveler's diarrhea, about antimotility agents such as loperamide, and I would generally recommend taking that with antibiotic treatment. However, if you have a very mild case of diarrhea, you potentially could take, some low dose loperamide and see if that helps out. Other things just to consider: antihistamines, antitussives, mucolytics, topical steroids for bug bites and rashes. The final thing that I'll kind of go over here is, and it's actually a situation that I ran into on one of my trips, is having a couple courses of HIV post-exposure prophylaxis. So I think having this is potentially pretty helpful, and certainly for unique situations. This was a medical trip that I went on with some students, and there was a needle stick unfortunately on day one. And so we did decide to go ahead and start the medication, and the student did just fine, of course. The tested negative for HIV and everything, but I think it's just important to have this as peace of mind. So the standard recommendations would be Truvada with dolutegravir. This is probably the first line therapy. Pretty well tolerated. I would really recommend dolutegravir has very high barrier to resistance. So if you are in an area where there may be some concern for HIV resistance, I think that this combination is going to be pretty good to have on board. The alternative to that would be another integrase inhibitor with raltegravir, and then Stribild, which is the once-a-day tablet, is an alternative to that, basically. So having basically a month's supply of maybe a couple months supply, if you have a big group, this would be a good thing to have on board. Okay. I think I've done enough talking. See if I can get out of this. Are there any questions?
What, Dr. Abel, what's your recommendation for sourcing, other than asking your PCP for a lengthy prescription course or a refill early, for obtaining some of the meds for international use?
Yeah, so we were lucky in San Antonio. We actually had a travel clinic. We had two of my colleagues would ran the clinic, and then being on a medical mission trip for like the HIV meds, we just wrote the prescription for each other, and we're able to. And then we told the pharmacist what our intention was, and they were able to fill it. So it can be tricky because those medicines can be pretty pricey. But I think the Truvada is generic now, so that one is pretty cheap. And I think dolutegravir and raltegravir are, I'd have to look to see if they're generic yet, but both of those should be, the one that would be expensive would be Stribild. That would be, because it's a pretty new medication. But we were able to get it for not too much money, actually. So, but that can be tricky, and I don't know. I don't know if things have changed in the past few years. So,
yeah, I know our employer here is pretty strict on prescribing meds for friends, colleagues, family. So yes, sometimes it can be a bit
a problem. Yeah, and I think that's where the travel medicine clinic, I think that's where that is really helpful, because then it's very formal. You're you're doing it in a proper way. And it's sort of documented. There's a medical chart record trail, everything you need for a proper clinic visit.
And Dr. Abel mentioned earlier about the travel insurance. I just wanted to mention a organization that the WMS is affiliated with, and membership of the WMS gets you a discount with, is Global Rescue, and not only travel insurance, but it covers search and rescue response, like extrication from a dangerous area or from a country if needed, and on the phone assistance with question answering regarding things like this, and event alerts about like outbreaks or problems in the area. So definitely something to look into. And I think some of the formal WMS Adventurous CME trips require some sort of coverage like that. So just something to keep in mind for planned trips.
Yeah, I would highly recommend it. It's been used a few times, and it was very helpful to have coverage.
I think it's good for people to definitely remember that if you aren't vaccinated, you need RIG for rabies exposures. We were on a trip in Peru, and the local medical providers there did not feel that RIG was necessary for a possible exposure. And they're like, oh, the vaccine will just be fine. But that was because they didn't have RIG. So just something really important, because I think it would be easy for a traveler to be led astray if they didn't know that.
Right. That's right. And I think it's a very expensive medication. The RIG it's many times more expensive than the vaccine, the vaccine being $1,500, $2,000, whatever it's going to be. RIG can be to 10 to 20,000. From what I had a big fight with an insurance company a couple years ago. I was able to successfully get the RIG, but it was definitely an issue. So you're absolutely right. I think that's a good point. That you really, and rabies can be delayed by years, even decades. So it's very important to have it properly treated up front.
And even going through that in your pre-trip planning, if somebody does get bitten and you don't have access to RIG, like what's your extrication plan? What's the closest place you can get them to that would actually have that? Because that was one of the situations that we kind of did some planning. Like, is it better just to put them on a plane back to the US? Do you send them to Lima? Like what, so pretty interesting to try to troubleshoot that on the ground.
Yeah. And that's where your insurance can help. Yeah. So it just depends on the situation, but you're absolutely right. It can be hard to decide, but that's, yeah, I think ultimately getting home is the best thing, right? If you have time, but of course time is of the essence with that. So just making sure you can get the RIG as soon as you can. So that would be the priority, I guess.
Interesting conversations, because I was still in the United States with our pharmacists to say, hey, well, you guys, release this to me because I'm traveling there tomorrow, versus, try to get this kid back from there. So really interesting. We ended up finding it in Cusco, so it became a non-issue, but was pretty interesting.
And of course, also administering it is pretty tricky. You have to be pretty familiar with how to, where to put it on the body, the wound itself. I mean, it's pretty, actually, you do need to be, needs to be done properly. So that's also an interesting thing to think about.
Yeah, I recently uncovered that our small outlying critical access hospital where I work did not have properly trained nurses of how to administer the RIG and vaccine initially. They were mixing not in the same place. Yeah, they were kind of mixing up which one goes in the IM and which one goes in the in the actual bite. So we had a little
may want to get that correct.
We fixed it.
Okay.
Hopeful that it's been fixed. And for those of this group who are maybe traveling to the Caribbean for a dive trip recently, let's just say Montezuma had his revenge on me at one point in the past. So careful what you eat and drink down there.
Yeah, salsa is very deceptive. I would be, that's where I got in trouble once. So I'm pretty good about, sticking with hot food and, avoiding salads, stuff like that, ice that hasn't been properly prepared. But man, the salsa got me once. I'll tell you what, that was not cool.
And just to cover, I know you mentioned taking anti-motility medicines only with the antibiotics. Can you mention the indication, whether it be dysenteric or non-dysenteric diarrhea?
So I think it's okay if it's pretty mild, like 1 or 2 loose per day, you're not feeling crummy. It's probably okay to just take loperamide. But if you're doing large volume, you may want to, that's probably what I would get a little worried about, that taking the anti-motility agent in that setting. And then in that situation, then you got to decide, okay, is this actually interrupting my trip? If you're going 4 times a day, that's bad, but it's not horrible, right? So you may want to still just see, is it going to go away in 4 or 5 days? If you're going 10 times a day, that's a different story. I mean, that you're going to get in trouble with that. Or if you feel just completely, you're like bedridden, that's a different story. So that's kind of, most of the time it really does go away on its own. So just kind of up to the individual. I know there's a low threshold to take antibiotics, but I would be pretty careful, especially because we're all probably colonized with C. diff. So from our work, so you want to be pretty careful about that.
What was one of your coolest or most unique, interesting cases you saw while international medical support?
Oh, let's see. The funny thing is, most of what we saw was so routine. That was what was crazy. We did see a ton of malaria. I mean, an absolute ton of it, especially in Uganda. Let's see what.
Yeah, malaria case I had as a resident, not personally, was the fastest I've ever seen an infectious disease doc come down to the ER. He was so excited.
Yeah. I did see, so was it more of a general medicine case, but it was a guy with tophaceous gout, and he had so much gout, it was actually coming through his skin. I've never seen such a dramatic case. Unfortunately, he did die of kidney failure. They don't have dialysis. They have a couple dialysis machines in the whole country available to people who don't have access to the means. But it was he was completely riddled with gout, and it was coming through his joints, just this white crusty. It was very, very interesting that you really see disease processes there that would never get to the stage that they do. 20-year-old boys with sarcoid tumors, sarcoma tumors that are just this size, that would never happen here. So it's just people not getting care. It's really crazy. But I will say Kenya, between the first and second year that I went, implemented a low cost sort of health insurance plan where you pay $500 a year, and it's a copay. And all of a sudden people got tons of access to Medicaid. So it really showed you that insurance does work, and hopefully and I haven't been back in a few years, so I wonder how things have gotten because they've implemented that change. But that was what was interesting, is just seeing disease processes that were much more advanced there than standard stuff that you wouldn't see here. So.
Yeah, one of my friends from residency, he used to lead a not-for-profit clinic in Haiti, and he supported it through for organizing marathons, and then took all the profits from that and tunneled it in. But they saw some incredible things down there. Mostly what you're saying is things that are routine here that get so profoundly advanced. And then now he does, through his fellowship in Brown, he has a clinic in Rwanda, and very similar things, transporting patients pretty darn far to get definitive care. Kind of reminds me a much more advanced level of working at Rockbridge in Lexington, Virginia. We can't do dialysis. We can't admit intubated patients. There's a deer in my front yard right now eating my plants. It's just kind of a different level. And it's kind of nice to work in a tertiary care versus critical access to see a bit of both.
Yeah, it is. It's nice to see the difference, I think. They also they find solutions to things that you wouldn't expect, and that's what I liked about the trips, particularly Kenya, working in the actual hospital run by Kenyans. So that I think that was the best experience.
Does anybody have any questions or personal experience they'd like to share? Okay, with that being said, I think we've gone past the hour mark here. I'm going to end recording.